Well, good morning and welcome to UW-Madison Global Health Institute's first Global Health Tuesday webinar of the 2025-2026 academic year. Thank you for joining us. My name is Kaylin Ostrowski and I am the Associate Director of the Global Health Institute. I'm delighted to welcome you to today's webinar, Measles Outbreak and Vaccines. At GHI, we are catalyzers and conveners who believe addressing global health challenges begins with dialogue. Our work is rooted in the Wisconsin idea, a practice taking knowledge and research out of the classroom and into real-world settings. Our Global Health webinar series features researchers and practitioners from the University of Wisconsin-Madison and around the world to highlight and examine the complexity of global health challenges and the many kinds of partners needed to address them. It is my privilege to introduce our panel, who will guide today's discussion and share their expertise and insights. Each speaker brings a unique background, highlighting the critical role of research and policy when addressing vaccines and public health. Before we jump in, a couple of quick housekeeping items. First, we are recording today's session, and the archived video will be available on our website at ghi.wisc.edu. And we are monitoring the Q&A section, so please post your questions and comments for the panelists there, and we will do our best to get to all of the questions during the Q&A session. We have a great lineup today, so let's go ahead and get started. Today, we begin by welcoming our moderator, Dr. James Conway. Dr. Conway is a professor in the Division of Infectious Diseases and Global Pediatrics at the University of Wisconsin School of Medicine and Public Health. He directs the Office of Global Health, leads the Pediatric Infectious Diseases Fellowship, and serves as the medical director for UW Health immunization programs. His work spans vaccine development, immunization system strengthening, and addressing vaccine hesitancy both in the US and globally. He has collaborated on the development of several major vaccines, including those for COVID-19, pneumococcus, meningococcal, and RSV. Welcome, and thank you, Dr. Jim, for joining us today.
Thanks.
Next.
Thanks, Kaylin. It's great to be with you. And really looking forward to all of our discussion with all of our panelists. I'm going to share and get started here. Oops. Yeah, so now I jump to the beginning. Hold on. So we have a great lineup today, and I'll have the pleasure of introducing each of our speakers. And I was basically asked to just sort of set the framework for what we're going to be talking about and give a little bit of information about measles and our current situation here in the United States. So measles is a viral infection with a relatively long incubation period, which is part of what makes it hard to control once it gets started in a community. It's also difficult because it starts out with fairly nonspecific symptoms that can be really similar to most flu-like illnesses. And only when it starts to develop the classic 3 Cs of the cough with some coryza and conjunctivitis do we even start to suspect it, and then get this rash that spreads downward from the head and then clears in the same pattern. It's really pretty rare in people that are vaccinated, especially those that have had 2 doses of the MMR vaccine. 1 dose generally provides about 93% of people with protection, and about 2 doses gets about 97% protection. So there still can be breakthrough cases occasionally. We care about it because about a third of people actually may have some complications related to the infection. Quite a few of the kids especially get diarrhea, get ear infections, get pneumonia, and can get secondary either bacterial or viral infections that take advantage of the situation. The really more tragic ones are obviously when central nervous system disease happens with encephalitis and brain swelling and inflammation, and then about 1 to 3 people per 1,000 may end up dying from this disease. And this is an extraordinarily contagious disease. This is probably one of the most contagious diseases we have on the planet at this point. Really casual contact in short periods of time can actually transmit this through airborne spread. And when we talk about how contagious a disease is, we use a term that we call the R0 factor, which essentially translates into if a person walks into a room of people that are unprotected, how many are going to get sick. And you can see that compared to things like mumps and rubella, and COVID probably had a R0 factor of maybe 1.5 or 2 at most. Measles has an R0 factor of 11 to 18, which means you need to have really, really high herd immunity to be able to manage this disease. herd immunity needs to be well over 90% to control outbreaks, and you need to get almost to 100% vaccine protection before you can really talk about eradicating the disease. And this is held up quite nicely when we look at the real world. So this is WHO and UN estimates of immunization coverage. These red and blue lines basically get us towards what looks like almost 90%. And you can see that the number of cases globally really decreased quite dramatically in the late 2000 teens as we got closer to that rate of being over 90%. But it was recognized even before the pandemic by WHO and many of us that the anti-vaccine movement and vaccine hesitancy was really going to represent a significant threat. And we knew that this was going to become a bigger issue when we got into the pandemic and saw how primary care services really dropped off and access to healthcare was really limited. And so we noted that there was a pretty significant drop off in vaccination that caused a uptick in measles that actually began during the pandemic and has continued. And my group started looking at this really early in the pandemic, and we modeled out that based on how many kids were missing out on doses of measles vaccine during the pandemic, that we were going to have to be immunizing about 10 or 15% more kids each quarter to even get caught up over about a year period. And that was only if we stayed at home in the Safer at Home programs into the spring or fall. Obviously, these lasted much longer, and so we really ended up with a much greater deficit for vaccines than we ever would have imagined. And so nationally here in the United States, the last year's data we have from the CDC shows that in these dark orange states, that less than 90% of people have had a full series of their MMR vaccines as they enter kindergarten. These lighter orange areas are areas where 90 to 95% of kids have had their vaccines, and then the blue areas are the areas that are most highly immunized. So you can see that we've got quite a few states and quite a few regions where we've been unfortunately sunk below that 90% rate. And our group more recently then started modeling where would the highest risks of outbreaks be based on both this decreasing immunization rate as well as rates of travel and other demographics about these communities. And we actually pinpointed with these little red dots using a regressive model where outbreaks had already happened and really correlated well. And you can see that we were already predicting that Texas and many of these areas of the Southwest, as well as scattered areas around the country, would be potential hotbeds where emergence of outbreaks could happen. On a larger scale, some of our colleagues, including some folks people may know, Peter Hotez and Yvonne Maldonado, modeled out from all vaccines in the United States where outbreaks would be likely to happen over the next 25 years and what kind of numbers of cases we would see. And you can see in both the blue and green areas that these are the areas that, based on their immunization rates, would be really at high risk for having lots of cases. And of course, even before the current measles outbreak, they had already modeled out that Texas would be a significant area with over 400 cases emerging with that decline in immunization rates. And lo and behold, we now do have, in fact, a nationwide outbreak that started in Texas and now has spread throughout the country. And we're certainly seeing the same thing happening with measles cases rocketing up in Europe and many other areas of the world. And to put this into context, on the bottom part of this slide is what was historically the rates of cases when we implemented the first MMR routine recommendation in 1983, and they added that second dose in 1989. And while this may seem like we're in significant rates here in 2025 and our last outbreak in 2019 and before that 2014, they're still not near where we were when I was in my pediatrics residency in medical school. And then on the top here, you can see what we've been seeing over time. And the pandemic came along at just the right time to stop that 2019 outbreak. But I think we knew it was inevitable as people returned to sort of more normalcy that we were due for another one, given what we've seen. And this current outbreak then, we're over 1,500 cases in the United States. 86% of the cases are linked to outbreaks, which means there's still cases also being brought in from outside the country. Younger kids and adolescents are the most affected, but I think it's important to remember that over a third of the cases are adults, of which the vast majority of these are unimmunized populations. Many hospitalizations at the rates that we would usually expect, 3 deaths so far, again, at the rates that we would expect, and about 2/3 of the states have had cases. So that's sort of the basic framework of what it is we're dealing with currently and kind of how we got to where we are. And With that, I get the pleasure of turning this over to our first speaker. So next, please welcome Jennifer Nuzzo. Dr. Nuzzo is a professor of epidemiology and director of the Pandemic Center at Brown University's School of Public Health. Her work focuses on global health security, pandemic preparedness and response, and health systems resilience. She co-leads the Global Health Security Index, the first comprehensive assessment of 195 countries' readiness to prevent and respond to outbreaks, and she founded the Outbreak Observatory to advance research with frontline health practitioners, public health practitioners. Previously, she was on the faculty at Johns Hopkins and served as a senior scholar at the Center for Health Security. She's an elected member of the National Academy of Medicine and the American Academy of Arts and Sciences. I'm really excited to hear her comments. Welcome and thank you for joining us today, Jennifer.
Thanks so much, Jim. That's a really great introduction to me, but also to the topic that I want to talk about. So I am going to share my slides here. Okay. And I deleted a couple slides because you covered them, which is I'll just start with kind of where we are now. So here's the kind of more granular look at the 2025 cases. As Jim showed, we have had more cases.
Jennifer, we're actually seeing your Microsoft screen.
Oh, that's interesting. Okay. I practiced before.
It's the dreaded dual screen problem, usually.
Let's see. 1 second. Better?
Yep, you're good.
Great. Changed screen numbers on me. Anyway, so yeah, so as we saw before, we've had more cases of measles in 2025 than we have had since measles was declared eliminated in the year 2000. This has also been the deadliest year for measles in that period of time. So a really extraordinary set of circumstances. And I just want to take a deeper dive in sort of what we're seeing with the outbreaks that are happening this year, but also crucially what it represents and the larger consequences of this. So here's just a kind of the state breakdown. So far, 42 states have reported measles in 2025. This is extraordinary in terms of this level of geographic scope. Even in the 2017-2019 outbreaks, we hadn't seen this many cases, this many states affected. As you can see here, different states affected in different ways. As Jim mentioned, the majority of these cases tied to the initial outbreak, largely that started in West Texas. But other states continue to have cases tied to outbreaks, but also tied to international travel. Sorry. This is a hard chart to show, but just to say, of all the states, here's the vaccination rates. And I just want to say, clearly this is being driven by suboptimal vaccination across the United States. Across the United States as a nation, we are below that herd immunity threshold. But even that statistic of where the United States is right now really, I think, masks vulnerabilities that exist in all states, because we interact with not the entire state, and the overall state's vaccination rates may, be in some instances, bolstered by, say, high vaccine uptake in, say, a very populous city. And so when you just look at the state's vaccination rate, and as you can see here with the states that are reporting outbreaks, even a relatively high level may mask vulnerabilities that exist within certain communities. So if you look, for instance, in West Texas, at the county level, you may see a suboptimal, but still not terribly low level of vaccination coverage. But if you look at some of the school districts, the entering vaccination coverage of kindergartners in some cases is like 14%. So that overall number really masks what are vulnerabilities at the community level. And that's ultimately how these outbreaks take off, because it matters mostly who you see within your community and what your community's vaccination level is. So really, to understand vulnerability, and I think that those models that Jim showed, I think, do this nicely, it really matters at the community level what vaccine uptake is. That the numbers at the state and the numbers in the county level and national level are useful guides, but they don't truly point to how vulnerable communities can be. We are on the verge as a country of losing our measles elimination status. So measles elimination is measured by for how long you have local transmission. And if you get to that 12-month mark, we are at the point of potentially losing our measles elimination status. The first case that the US reported in this 2025 outbreak was on presidential inauguration day, so January. If we come to January and we are still reporting local transmission, the United States is on the verge of losing its measles elimination status. Now, people ask me, what does that mean? And it means, I mean, practically speaking, I think one of the big things is just, it's a giant embarrassment. It is a stain on a country that otherwise has technical resources and the availability of vaccines to prevent losing measles elimination status. But it also has a lot of important operational and other implications as well. And I want to kind of walk through some of those. So my group and I had studied the last prior large measles outbreaks that were happening in the United States, the response to the outbreaks that happened in 2017 and 2019. We talked to the public health practitioners who were involved in responding to those outbreaks. And we learned a lot about how challenging those experiences were. And in many instances, the challenges that we saw the public health departments struggling with in those outbreaks foretold a larger story that we then saw play out in the US response to the COVID-19 pandemic and beyond. I mean, these are the challenges that we are still dealing with when we're talking about responding to a contagious infectious disease outbreak. So first of all, as Jim mentioned, measles is a highly contagious disease. Just to show it, there was a recent systematic review looking at what the estimated basic reproductive number of measles is. As an epidemiologist, I'm obliged to tell you that this is not an inherent property of the disease. It is a function of the disease in particular populations. And so we do see a range. And this review found that the range is a little bit different than what it's typically reported. Typically, we say 12 to 18. This review said, well, it's actually a much larger range, and in some places much lower, and in some places actually much higher. But just to say, this is one of the most contagious diseases that we can deal with. And just to show you differences in different populations, here's a graphic from that paper. Differences in the pre-vaccine era versus the after vaccine was introduced. Not clear exactly why. It might be difference in populations that were included in the studies, but just to say, measles, highly contagious. So because it's highly contagious, it is the poster child for use of contact tracing, right? Once you find someone who's infected, you want to know who they may have exposed so you can find those people and make sure they stay home until you know for sure that they're not going to pass the infection on to everybody else. Doing that is really key to controlling these outbreaks. One of the things we found in studying the response to measles in the US in 2017 to 2019 is that health departments were largely not doing contact tracing for measles outbreaks, which is really quite stunning because if there were a disease for which you'd want to do it, measles really is one of them. And one of the things we found is that health departments circa 2017, 2019 just didn't have the staff to do contact tracing. It was too resource intensive. So what did they do instead? They put out press releases that said, we found measles. We found measles in this public place. If you were in this public place between this time and this time on this day and this day, go see your doctor. Basically pushing on to America's healthcare system, which is stressed on a daily basis, the work of public health departments, having, doctors and nurses try to figure out what to do for patients as opposed to what health departments would have typically done in previous outbreaks. And, this I think was an important warning sign for us, because if you remember 5 years ago at the early start of COVID, when we were watching countries around the world sort of swiftly respond to the introduction of COVID to their countries through case-based interventions that weren't just about shutting down entire cities, but going after individual infections and who they may have exposed. What we found was that the United States was not in a great situation to be able to do this because we lacked the staff to be able to do contact tracing. In fact, there was a pretty big a bolus of funds appropriated by Congress in order to help states get the people to do contact tracing. I will tell you, contact tracing is more of an art than it is a science, and it's very, very hard to do in the midst of emergency. It's very hard to suddenly train a whole bunch of people who have never worked in public health before and train them to be able to ask very sensitive questions about who they were with and when they got sick and who they may have exposed, and to be able to call those people and convince them to stay home, even though they at that point may not be feeling sick themselves. So just to say, the challenges that the United States had in responding to COVID, we saw signs of it in responding to the measles outbreaks. And so part of why we should be talking about measles today isn't just because measles is a bad disease and we don't want it to spread, but because it is a canary for how the United States can respond to outbreaks of other diseases, including even more serious scenarios. The other thing we saw in the response to measles in 2017 and 2019 was how incredibly difficult it was to deal with the misinformation that was really paralyzing efforts to control the spread of measles. Let me tell you, hearing from the public health practitioners about the level of misinformation that they were combating, it was stunning how sophisticated the campaigns were, to the point where public health practitioners were actually even wondering who was behind those campaigns and whether they were even members of the community or even residents, citizens of the United States. There were questions about whether information warfare was being waged. They were having public health communications being spoofed. Very, very sophisticated campaigns. And it's probably not surprising to anyone who's worked in public health, there was absolutely no resources or abilities to even handle this. This should not be surprising given the level of mis and disinformation we routinely see challenging public health right now, including in responding to the 2025 measles outbreak. There was a period of time in which the Children's Health Defense, this is the anti-vaccine group that Secretary Kennedy used to be part of, completely spoofed the US CDC website, made it look very much just like this US CDC website, but populated it with a lot of false information about measles and measles vaccines. So just to say that this is a challenge that we have not yet figured out how to solve, and it was already bad circa 2017, 2019, and it has just gotten worse since. We also did another study looking at some of the actual operational challenges. And one of the things we found was that there was a lot of confusion about what actually to do in responding to measles, including who do we exclude from congregate settings? There was an outbreak of measles in a county in Oregon, and it happened in a daycare. So a unvaccinated daycare worker came back. This is like kind of a nightmare scenario from travel, developed measles, exposed a whole lot of children who were too young to be vaccinated. And there was a lot of questions about how wide they should kind of cast the net, so to speak, in terms of who to keep out of daycare. When we're talking about what this means, practically what this means is telling parents that their children cannot come back to daycare for potentially 21 days. And, that had a lot more significance prior to the COVID-19 pandemic when we shut everything down. But thinking about the disruption and the workforce challenges that can result from outbreaks of measles, this is just one small one. But, think about this playing out throughout the country, measles incredibly challenging and disruptive outbreaks. And then I'll finally just say is that measles, because it's so transmissible, because it spreads in these clusters, and because we tend to see these sort of like wildfire outbreaks, it's just incredibly costly. It is very costly for public health departments to respond to. Here's just one estimate, and I think the estimates are going to very much vary depending on the populations in which measles are spreading. But by one estimate of a prior outbreak, tens of thousands of dollars per case. And, we are over 1,400 cases of measles this year. Thinking about what that means and thinking about the numbers of measles cases that we have had since measles was eliminated, just to say, if we let this thing continue, this is an incredibly costly endeavor that the United States will be on the hook for. And, if you compare that to the relatively low cost of preventing measles in the first place, it just is another reason to speak to why this is not a situation that we can let get out of control. And so I'll end there just to say that we are regularly tracking the measles outbreaks that are happening in the United States. We may have a government shutdown tomorrow, so non-governmental efforts to keep the public apprised of what's going on with measles will probably, unfortunately, continue to be important. So if you're interested, then feel free to sign up for our tracking. So thanks so much.
Thanks so much, Jennifer. That was terrific, and a real peek behind the curtain at what these things really mean on the ground for people. Next up, I get to welcome my friend, Dr. Jonathan Temte. John's a professor of family medicine and community health and the associate dean for public health and community engagement here at the University of Wisconsin School of Medicine and Public Health. He earned his MD and PhD here at UW-Madison. Has published widely on reproductive ecology as well as infectious diseases. Dr. Temte has been deeply involved in shaping vaccine and immunization policy at both the state and national levels. He has chaired the U.S. Advisory Committee on Immunization Practices, the infamous ACIP that we heard so much about over the past couple of weeks, back in a very different era, and led multiple CDC expert panels on measles and rubella elimination. And he currently chairs the Wisconsin Council on Immunization Practices. Welcome, and thanks for joining us, John.
Well, thank you so much, Jim. It's a pleasure to join in today. Sometimes to understand where we are, it helps to understand how we got here. So I'm going to provide a brief history of measles in the United States. So first and foremost, you have to keep in mind that before vaccines, measles was ubiquitous, meaning we had about the same number of cases each year as the birth cohort. In fact, by the time a child entered adolescence, the likelihood of measles was almost 100%. At that time, we had about 500,000 cases reported annually, but we think there were probably more like 3 to 4 million cases overall with 500 deaths. The highest incidence was in younger school-aged children. But the thing about measles is there is no non-human host and a single antigenic type, which makes it ideal for not only elimination, but global eradication. So I'm going to just provide a quick timeline here, going back to 1993 or 1963 till present, and take you through this. So 1963, vaccines arrived. We had our first licensed vaccine. And if you take a look at the graphic, you saw an immediate and profound reduction in cases. In fact, it was so incredibly effective. 3 years later, the CDC announced a national measles eradication campaign at the American Public Health Association meeting. Going further, as the vaccine was successful, one of the unfortunate attributes is mothers had immunity based on vaccine and not natural infection. And in fact, their infants, so a generation later, 1989, we saw a resurgence of measles, particularly in the youngest children. And so in 1989 through 1991, there were 55,000 cases, 123 deaths, which was very different from where we had been. The graphic over on the left is a log scale of cases. So it really didn't have the same potency as before, but we still saw that resurgence. And this led to our second dose that has been alluded to, which takes protection up to a level about 97 to 98%. 1998, a watershed moment with the publication of this paper by the title of, oh, sorry about that, go back. The Elio-lymphoid nodular hyperplasia, nonspecific colitis, and pervasive developmental disorder in children. This was the watershed event in which somebody, Dr. Andrew Wakefield, who has had his license revoked from the UK, but associated the measles vaccine with autism. As you can see, this was retracted by the journal. Dr. Wakefield lost his license. The co-authors recanted their authorship. And in further evaluation, it was found that his research was actually fraudulent. But this has had an impact that carries with us into today. In 2000 was the CDC's measles elimination meeting. This is my very first introduction to measles. I represented the American Academy of Family Physicians at this meeting, and we met for a day and a half in Atlanta, reviewed an incredible amount of molecular epidemiology, looked at surveillance, looked at vaccine effectiveness, and we were able, after that time, to declare measles eliminated in the United States. And as Dr. Nuzzo has noted, measles elimination is defined as the absence of endemic measles virus transmission in a region or other defined geographic area for at least 12 months. But this is the important part, in the presence of a high-quality surveillance system that meets the target of key performance indicators. And I just will take a pause here and say, as we dismantle our CDC, we are dismantling this really important element that allows not only national, but global tracking of disease. Well, in 2004, the Institute of Medicine took on the issue of vaccines and autism and found no association between vaccines, between thimerosal, between measles vaccine and autism. And in 2007, there were a number of federal court cases heard under the special master's jurisdiction. And if I can just read one of the proclamations from the special master or the judge, after careful consideration of all the evidence, it was abundantly clear that the petitioner's theories of causation, i.e., vaccines causing autism, were speculative and unpersuasive. This is one of the nicer comments from the judges. There are others out there. Unfortunately, this didn't go very far in our age of purposeful disinformation and misinformation. Well, in 2011, I was called back and was one of a 5-member panel that reviewed all the evidence of elimination. And we were able to, again, reaffirm that measles, rubella, and congenital rubella syndrome were eliminated in the United States and across the region of the Americas. But we noted in our report that increasing rates of vaccine exemption among school-aged children in a number of states and demographic pockets of susceptibility to measles and rubella, which collectively might sustain endemic transmission following international importation. And as Dr. Nuzzo and Dr. Conway pointed out, this is what we're dealing with now. Not only declining overall, but these pockets of much higher vaccine avoidance. Well, in 2019, we came very, very close to losing our elimination status. We were essentially a week shy of that 52-week point in which we would have lost this. It was largely powered by a large outbreak in New York City. Unfortunately, it came to the end and we retained our elimination status. And that brings us to today, 2025, and what's going on, as we've already seen in terms of the record number of cases, the most cases per year since elimination. And I'll just point out, so as we've already seen, the Texas outbreak has come to the end, but the ongoing outbreak continues across the United States. In the upper panel, we see the county-wide rates of measles vaccine coverage, which have declined dramatically, especially over the last 5 years. So I'm going to just end up with, a little bit of caution in terms of what you see, what you read, what's available in America's media. This is from the Washington Examiner. The Trump administration's response to the measles outbreak, led by Health and Human Services Secretary Robert F. Kennedy Jr., met the moment. It was prompt, aggressive, and wholly effective. And this week, thanks to the Secretary's leadership and tireless work, Texas health officials declared the outbreak over. So this is from Washington Examiner, Kaiser Family Foundation. All of us at CDC trained for a moment a massive outbreak, said a CDC researcher. All this training, and then we weren't allowed to do anything. As measles exploded, officials in Texas looked to CDC scientists under Trump. No one answered. And you can see some of the quotes from here. So we get a dichotomy of information. and one has to be very, very critical and careful in terms of information. So I'm going to end it up here and turn it over to Dr. Moss, but thank you very much.
Thanks so much, John. Really interesting and a great perspective. And as he mentioned, last but not least, I get the pleasure of welcoming Dr. William Moss. Dr. Moss is a professor of epidemiology, international health, and molecular microbiology and immunology at the Johns Hopkins Bloomberg School of Public Health. He serves as executive director of the International Vaccine Access Center and deputy director of the Johns Hopkins Malaria Research Institute. He's a pediatrician with expert in infectious diseases. Dr. Moss has worked extensively across Africa and India. His research focuses on childhood infections in resource-limited settings, with particular attention to measles control, malaria epidemiology, and the impact of HIV on child health and immunization programs. Welcome, and thanks for joining us today, Bill. I'm really excited to hear your comments.
Yes, thank you very much, Dr. Conway, and it's great to be with this group, and very important information has been shared. What I'm going to do is take a more global perspective and just very briefly describe the current global measles situation and how it links to what's happening here in the United States. And I will cover some of the ground that my colleagues have covered. But I just wanted to start out, I'm using this title, Measles, What Goes Around Comes Around. And I wrote this piece back in, we published this piece with my late mentor and measles expert, Dr. Diane Griffin, back in November. It actually came out 2 weeks after she passed. But we were kind of commenting on the increasing number of measles cases in 2024 and what was happening globally, not fully anticipating what happened in 2025, but obviously the situation is much worse, both here in the United States and globally. So we too have a tracker. I know Jennifer has a tracker at Brown. This was established by my colleagues, led by Lauren Gardner at the School of Engineering, and Jennifer, when she was here at Hopkins, worked closely with Lauren on the COVID disease tracker. So this is the image from our tracker, which is hosted on the International Vaccine Access website from this morning, showing a total of 1,522 cases. And the reason I show this map is we try to distinguish imported cases from local cases, and you can see the imported cases in red, the red dots. And they are kind of scattered, around the country, but perhaps a little bit more at the coastal areas where people will enter. And there was an earlier study led by the CDC showing international importations of measles virus into the United States from a much longer period, from 2001 to 2016. Here, I think it's a little easier to see the clustering of cases on the coast where people are likely to enter the country, but also for cities such as Chicago. And I know Dr. Conway talked about this in his work in predicting where measles outbreaks were likely to be here in the United States, and other groups have done this as well. Dr. Conway pointed out Dr. Peter Hotez's work on this. But basically what one can do is, if one understands where measles cases are occurring globally, where the transportation or air networks are, and then where the clusters of susceptibility are in the United States, one can then assess the risk of importation. And so what I am showing here is in the upper left is a figure from MIT showing different air travel patterns into the United States, particularly from Europe, you can see. So we're particularly prone to importations of measles virus when there are large numbers of cases in Europe. The bottom left is a more recent paper from Lauren Gardner's group looking at MMR coverage levels at the county level. And then on the right is a slightly older work by Lauren Gardner's group, but basically kind of similar to what Dr. Conway showed, where there's a likelihood of measles outbreaks in the United States, kind of putting these different data streams together. And this is really just to set the stage that and make the point that is probably likely obvious, but measles here in the United States, because we have eliminated endemic measles virus transmission, as Dr. Temte pointed out, we're really susceptible to importation from what's happening globally. So what's happening globally is going to change the risk here in the United States. So let's take a look at that. So this is the most recent data from the World Health Organization showing reported measles cases globally by WHO region. And just to highlight that, or note first that the reported measles cases globally are grossly underreported. So the true numbers are much higher than this. Even as Dr. Temte said, even in the United States, that was the case. But I think the overall patterns give us a true picture. And what we can see is that there was a global resurgence of measles in 2019, and then the pandemic hit, and for a number of reasons, including all the measures that were put in place to stop the respiratory spread of SARS-CoV-2 also had an impact on other respiratory viruses, including measles virus. There was also probably an impact on disease surveillance as well, but we saw record low numbers of reported measles cases in 2020 after the pandemic started. And then what we've seen, and you can see here, is a steady kind of increase in the global reported numbers of measles cases up through 2024. 2025 is still below that 2024 level, but no doubt an increase over, since the resurgence in 2019. And this somewhat mirrors the cases in the United States. What I want to, if we look at the kind of the country level, this is a WHO map showing the number of measles cases over the past 6 months by country. The darkest blue represents those countries, 26 countries or 13%, that have reported more than 1,000 measles cases in the last 6 months. And I think what's striking here, first of all, is it's a lot of blue. It's a lot of dark blue. We can see some of the lighter blue in South America, for example, or Australia or some parts of Europe that have reported fewer cases. But what's striking too is North America, where there have been more than 1,000 cases reported in Canada, obviously in the United States, and in Mexico, and I'll show you those numbers. But so the measles cases in the past 6 months are not just isolated in low-income countries. Now, in the table on the right, you can see those countries that have reported the most number of cases. And so we have Yemen, Pakistan, India, Nigeria, Afghanistan. But then down at the bottom, Canada and Mexico kind of make that top 10 list. And if we dive a little deeper into what's happening in the Americas, this is another figure from the World Health Organization showing the WHO American region. Again, you see that global pattern of a high number of cases in 2019, then really going down to record low numbers during the pandemic. But in the Americas, it was really in 2025 that we've seen the resurgence. And that's driven by these outbreaks in Canada, Mexico, and the United States largely. So if we look a little deeper into those countries, I've taken some WHO figures. And just to give you a sense, so with this WHO figure, I have the United States at the top. At this time, it was 1,400 cases. Now it's over 1,500 cases. But you can see in Canada, 4,220 cases, and in Mexico, also around 4,000, just over 4,000 cases, 4,353 cases. So these three countries in North America have really had a resurgence of measles in this calendar year. So what's driving this? Dr. Conway showed a similar figure. This is a little more updated, showing coverage in the red line for the first dose of what we call a measles-containing vaccine. So that can be a monovalent measles vaccine, measles and rubella, measles, mumps, rubella. And then for the second dose in yellow. And so, as Dr. Temte said, a second dose of measles vaccine was introduced following the large outbreaks in 1989 to 1991. Globally, it's taken more time for countries to introduce that second dose and globally to achieve higher coverage. But I think what is most striking to me about the MCV1 line, the red line, is basically the plateauing of coverage. And this, to me, is the big global challenge for measles control, elimination, and potentially eradication, is that our global measles coverage with the first dose has really stagnated, around 85% for the past almost 2 decades, which means that about 15% of the global population of children, which has been increasing over this time period in terms of absolute numbers, have really been left out. There were what we call the measles zero-dose children. You can see that for MCV1 in 2019, the coverage was 86% globally. There was a drop as a consequence of the COVID pandemic down to 81%. We've begun to see some recovery, but we still haven't achieved the coverage that we had globally with MCV1 back in 2019. And the World Health Organization and partners are really trying to increase this. They've implemented a program called the Big Catch Up to try to catch those children, get those children vaccinated who were missed during the pandemic. We have seen a slow but steady increase in MCV2 coverage, which is a good thing, but still there's this gap between MCV1 and MCV2 coverage. So many children are getting that, of the children who are getting that first dose, many are missing that second dose. The bars show measles zero-dose children, those who did not receive the first dose of the vaccine in red, those who did not receive a second dose in gray. You can see that measles, the absolute number of measles zero-dose children on that bottom figure has actually increased from 2019. We've gone from 19.3 million to 20.6 million. Although the good news is that the number of missing the second dose has decreased. But again, the big challenge globally is reaching those 20 million children who have not received their first dose of measles vaccine. And this is going to become increasingly difficult because of the funding cuts that particularly Gavi, the Vaccine Alliance, has faced, but also the World Health Organization and other global partners. And this is driven in large part, but not solely, by the U.S. government withdrawing funds for Gavi, but other important partners, such as the United Kingdom, have also withdrawn funding. And so right now, the Gavi, the Vaccine Alliance, which supports measles and rubella immunization in many low-income countries, so-called Gavi-eligible countries, particularly mass vaccination campaigns that are used to fill immunity gaps in those countries that have weak routine immunization programs. Gavi's facing a $3 billion deficit from what they had hoped to raise for what is called Gavi 6.0, which starts next year and goes through 2030. So at a time when we've seen slipping demand because of vaccine hesitancy, we were also seeing a decrease in investments in global vaccination. And as we see increasing measles outbreaks globally, that's going to place the United States at greater risk for importations. As my colleagues have pointed out, there are communities within the United States where vaccine coverage is low. And so I fear we're going to see increasingly frequent and larger measles outbreaks here in the United States as a consequence of these different forces acting. Thank you.
Thanks, Bill. That was really terrific, and we really did touch a lot of bases here. That was a great way to finish it up. We've got a little bit of time for questions, so if people have questions, please put them into the Q&A, and I'll start with the ones that we have here right now. So, first one, we can have everybody sort of take a stab at it, both as a specific and then as a more broad topic. I noticed a large portion of the map where measles was predicted to outbreak looked like it was in the Southwest. A large portion of that land is cared for by native nations who might, rightfully considering the history of our medical system, be wary of vaccines. Is that at all correlated? And if so, how do we increase access and trust in Western medical science? And I think we can also kind of more broadly ask, how do we take all this important information and communicate it in a way and gain more trust in general? And you guys can all take a crack at that one. Bill, you want to go first because you're still on mute?
Yeah, no, I can. It's a very important question, and there are communities. I'm gonna touch on it a little more broadly because I think it is an important issue more broadly here in the United States, where there are communities, and they can be indigenous communities, but also particular religious groups, as we've seen. And the outbreak in West Texas was largely driven by an outbreak in a Mennonite community, as well as the outbreaks in Canada. And so rebuilding trust in these communities is critically important. And a part of that is getting the message right, but I think even more importantly is getting the right messengers, and having people who are trusted by those communities and having them become vaccine advocates and communicators in their communities. And there's an old quip that trust is easily broken and slowly rebuilt. And so this is not something that's going to turn around very quickly, but all of us who believe in the value of vaccines need to be part of this. But getting the right messengers, I think, is really critical. And I'll let my other colleagues chime in.
Great.
Well, I'll follow up on that, which Bill alluded to. We now have at least 2 generations of physicians and PAs and nurse practitioners in this country that really haven't seen bad infectious diseases. We can look at measles, but I can say the same thing about pneumococcal pneumonia. I can say the same thing about H flu, meningitis. These are things that I saw as a medical student and a resident, and I haven't seen in my 33-year career as a family physician. So when we talk about having trusted messengers, I think it's imperative that we have that historic perspective that we share with our trainees about how devastating some of these diseases can be. And every now and then we get a little bit of insight, for example, with the acute necrotizing encephalitis associated with influenza in the past year. But we really have to emphasize that any child who is hospitalized or dies or is permanently injured from a vaccine-preventable illness is a tragic event because these are largely preventable. And we don't have to go that route. But I think we really need to not only educate the public, but we have to educate ourselves.
Jennifer?
Yeah, I was just going to say, I wouldn't always assume that lower uptake is necessarily related to trust. Not to say that trust isn't important, but I think one of the things that we learned in seeing what the impact of active efforts to boost vaccination uptake is, and particularly in racial and ethnic minority groups, is that often it's tied to lack of access or lack of infrastructure. So yes, trust is, I think, an important problem in public health. I think sometimes we use it as a catch-all for all the hard stuff, and sometimes it's really about just making dedicated efforts and making it easier for people to connect with the resources.
Yeah, it's a great comment. That was actually similar to what I was going to say. There's an equation here, and there's certainly trust on the receiving end, but there's also improving trust on the other end. And part of that trust is making more access available because it shows how much we value and consider that important from the healthcare systems and from the governmental side. A different question, but very specific, but I've been curious about this myself. This is probably towards John. Once measles elimination status is lost, how difficult is it to regain it? Have other countries fluctuated between losing and regaining it? And also, are the global standards for elimination easy to meet, or is it a bar that's set too high or too low?
Yeah, it's a great question. And in retrospect, one can look at nations across the world that have lost elimination status. And I think, as Jennifer pointed out in her talk, that it's really a marker for political instability. It's a marker for societal chaos. And so we have to keep that in mind. So, and I also mentioned that it is critical to have that infrastructure that can do the case finding, the surveillance, the follow-up. Do you have to have, a laboratory system that can identify the global origin of a virus? Is it imported? Is it connected? And these things are difficult. They take a very intact public health system. And my worry is that we are dismantling that public health system, which makes it much more difficult to regain that elimination status if you lose it, because it's predicated on having that intact public health system. There have been many examples of countries that have lost elimination status for a year or longer and then have regained it. But again, I think the challenge right now is the bigger picture on that, not only US, but national public health, but global public health commitment, resources, and the ability to do that tracking.
Great, that's really helpful. Somebody texted me another question that's sort of a follow-up to that, maybe to Bill, but everybody can take a crack at it. How good is the quality of surveillance data from around the world? In other words, how good is the network and how strong is the support? When there's attention to things, Yemen obviously leads as far as cases, but there's always the question of undetected cases out there. So what do we know about the quality of data?
Yeah, so first of all, the quality of the data is quite variable, depending on the country. There's no doubt that the number of measles cases reported to the World Health Organization is grossly underreported. And one way you can kind of see that is if you look at the number of measles deaths reported as well. If you took the number of deaths over the number reported, you actually get a much higher case fatality ratio than one would expect. So it's several orders of magnitude of underreporting. But what I will say, Jim, is that the CDC and the WHO had built a really valuable global measles and rubella laboratory network to help with the surveillance and support countries. And that is under threat because of the current funding cuts. So it goes to Dr. Temte's point about, undermining surveillance here in the United States with what's happening at the CDC. That's happening at a global level. So we're going to have even poorer quality data going forward.
Great. Well, thanks everybody for your comments. This is a really great discussion. I'm going to turn it back over to Kaylin to wrap up, but we really appreciate everybody joining us today.
Yes, thank you all so very much. What a wonderful and fantastic discussion. That is unfortunately all the time we have for today. If everyone could please join me in thanking our esteemed panelists for sharing their invaluable insights and perspectives, that would be wonderful. I'd also like to thank all of you for joining and sharing your questions during the discussion. Be sure to check out our website, ghi.wisc.edu, to learn about our upcoming webinars and to find today's archived video. And last, mark your calendars. Our next webinar is on Tuesday, October 28th at 9 a.m. Central, where our webinar will explore community-driven solutions to maternal health disparities. Thank you, everyone. I hope you have a wonderful rest of your day. Thank you.